Our next session is it's a symposium for Abbvie, and the speaker going to be Dr. Mohammed Shahab. Dr. Mohammed Shahab, consultant of gastroenterology at Hayal Habib Gastroenterology Center, and he will talk about the updated data for Rinvoq and SKyrizi in the management of inflammatory bowel disease.
Good afternoon, everyone. Thank you, Dr. Ahmed, for the introduction. Thank you, Abbvie, for inviting me. In this maybe 15 to 20 minutes, I'll review the data for the let's say new kids in the block, so upadacitinib and risankizumab in the management of inflammatory bowel disease. So starting in upadacitinib in ulcerative colitis, so upadacitinib has been approved for at least now 7 indications. We have it for psoriatic arthritis, rheumatoid arthritis, atopic dermatitis, and atopic dermatitis for the age of 12 and above, which is like a good hint for our patients in IBD, in UC, and CD, and other rheumatological diseases. So this is like the phase 3 RCT for upadacitinib in UC. We know there is 2 induction trials you achieve and you accomplish. Both have upadacitinib 45 milligrams QD for 8 weeks, and those who responded were randomized to the UAchieve trial. There's 2 doses, 30 milligram and 15 milligram, and those who did not respond were to an open label and extended 8 weeks extension for another 8 weeks. Those who lost response in the maintenance phase were allowed to go to the long-term extension trial, and the primary endpoint were clinical remission at week 8 and clinical remission at week 52. So we can see here the results. The first, the mucosal healing in patient with OPA versus placebo at week 8. You can see in the both you achieve and you accomplish induction trial, there is a statistically significant difference. You can see a good deltas here in both doses. The 45 in the induction trial, and then in the maintenance, both the 30 and 15, they do it better than placebo, and there is numerical improvement or better like the 30 milligram than the 15 milligram in voice. And do you hear me? Yeah. And the 30 milligram did numerically better than the 15 milligram in the maintenance you achieve trial. Then also like the newer outcome, which is histological endoscopic mucosal healing, and you can see this is a combined outcome with endoscopy and histology. And this is a score of endoscopy score of Mayo 1 or 0 plus Juba score of less than 3.1. And you can see like as early as 8 weeks, there is an improvement in histology and endoscopy in the induction trial. And we can see also in the maintenance trial you achieve there is better deltas between the upadacitinib versus placebo. And we can see also the 30 milligram also did numerically better than the 15 milligram. So from this we can say like upadacitinib did better in terms of mucosal healing in the induction and also in other newer outcome, endoscopic remission, HEMI, than placebo at week 8 and also at week 52. So one of the some challenges when we use biologics and so on, because we want a drug that works fast. We want a both an effective and work fast, and here we can see like in clinical response with OPA 45, and you achieve and you accomplish that there is an improvement in a clinical response as early as week 2, and you can see the separation nicely started at week 2 between placebo and between the upadacitinib, and this is like one of the say like fewer drugs that can work as fast and effective in IBD. This is in ulcerative colitis, and we know now the pros and patient-reported outcome are important outcomes. Now we look for bowel urgency has been a newer outcome in some clinical trial, being as a secondary outcome. And you can see here in bowel urgency is a new achieve and new accomplish. Patient had better bowel urgency symptoms improvement in both trials versus placebo. And also abdominal pain was observed, improvement in abdominal pain in the induction trial as early as week 2, and both you achieve and you accomplish trials. So we know now upadacitinib achieved all the primary and secondary endpoint in the you achieve and you accomplish trial. The induction trial also achieved all the clinical response as early as week 2, the 45 milligrams, and we have higher rate of other improvement in other outcomes as well. So how about clinical remission? Now, and this is by naive versus biofailure, with an important clinical questions. We have a lot of patients who failed biologics, and you can see here, this is week 52, clinical remission rate, and we see the 30 milligram, like 53% had clinical remission, and the 50 milligrams of 42, and versus placebo only 15. So there is a very nice delta here in the bio-naive patient. And interestingly, in the bio-responsive patient or biofailure patient, OPA did very well compared to placebo. This is not very often seen in other trials, that you have OPA as a second, or like a bio-experienced patient. We have a very nice remission, clinical remission in OPA 30 and 15 milligram versus placebo. This is like the long-term extension trial. So those patients, after 52 weeks, they were also followed in an open-label extension trial for another 48 weeks. So this is 2 years, and you can see the response rate. There is a durability of the all outcomes after 2 years of treatment. What about safety? We know safety is a major concern, especially with JAK inhibitors, and we know OPA has been there for a while now. We have many indications in OPA, and also what we mainly care about, like MACE and DVTs, and we can see here, like aspergillus and IBD and UC and Crohn's disease, we have also low risk of major events such as cardiovascular disease and MACE in those patients. However, we try to avoid them in the elderly patient and on those who have already risk factors. How about OPA and Crohn's? So we know that OPA had shown mucosal healing early at week 12 and 52. It has a rapid response and durable response in Crohn's disease, well-characterized safety profile so far, and it's been only medication approved for both UC and CD and IBD. This is the phase 3 trial, the UXL and UXceed trial. The UXceed is 100% with prior biologic failure, which is not, this is very difficult patients, are not an easy to treat patient, and the UXCL has 55% without prior biologic failure. And the interesting part of this trial also, there was forced steroid tapering at week 12. They're not allowed to get steroid anymore, any more than 12 weeks, and then clinical response was assessed and other outcomes. Those patients who did not reach outcome at week 12, and they allowed to have an extended induction for another 12 weeks, so a total of 24 weeks period. Maintenance trial, the same doses as the in UC, 30 milligrams, 15 milligrams, and versus placebo. So this is a mixed population, as I mentioned earlier, and the UXceed, all of them had biologic failure, which is, those are the difficult patients. And this is the first ever forced steroid tapering during induction. And there is a primary endpoint here, both clinical response, which is stool frequency, abdominal pain, plus endoscopic response were measured together. And we can see here endoscopic response, a clinical response for both UXceed and UXceed. There is a statistically significant difference between drugs and induction, and placebo, OPA versus placebo. And also in the maintenance trial, we can see the 30 and the 15 are better than placebo. 30 is numerically better than the 15 milligram. Mucosal healing at induction at week 12, also we can see there is better in the patient who did opasitinib versus placebo, and we know mucosal healing as early as this. Also, this is not 25% of patients, but you can see this is SCD of 0 in patient with SCD, and this is a very difficult outcome to achieve, and achieving in those patients early at week 2, that will be a very, I would say it's a very good and promising results. So if we go endoscopic response and remission by pre-biologic failure at maintenance at week 15, and you can see this is pre-biologic failure, and you can see that OPA and without pre-biologic failure, the 40, 30, and placebo, they did better. But with biologic failure, also the endoscopic response and endoscopic remission was better than placebo. And this is also an outcome that we look for, not just a clinical remission, also endoscopic response, endoscopic remission are better than placebo in patients with biologic failure. And I think also this is a very, quite important deltas here for those difficult population who failed already biologics. So this is all over mucosal healing at week 52, And you can see like 30 milligram, 24% reached mucosal healing versus 13 versus only 4 in the placebo. And here again, this is CDC score of 0, which is not as a very difficult outcome to achieve. So this is a post-hoc analysis at week 52, achieving mucosal healing, and those who achieved the mucosal healing, and you can see the both. So the gray is the patient who did achieve mucosal healing, like around 58% of them also achieved clinical remission, and also like in all in the 50s they reached corticoid-free CDI remission, and IBDQ also improvement, and also last one, the FACIT-F is the fatigue score. So those who reached endoscopic remission, you can see also majority of them also achieved those other important outcomes such as clinical remission, steroid-free remission, IBDQ, and fatigue. So also like as we saw in the UC, like there is also rapid response induction at week 2. So we know from here, from OPAC, it works fast, and in week 2 we see an improvement in both in UC and CD. Here in CD, because we see as early as week 2. So stool frequency and abdominal pain we see, and this is a post-hoc analysis, and the UXL and XC trial, and then you can see the abdominal pain, which is a score of 1 or less, stool frequency less than 3, and you can see that opasitinib in the induction did better than placebo. This is the extension trial. So those patients, we're talking about endoscopic remission through week 48. So those patients who finish the 52 weeks, then if we continue for another year, how many of those had endoscopic response? So you can see here like the opasitinib 30 and 15 did better than placebo, and you can see in the endoscopic remission also around like half of them would say had also achieved outcomes. So if you wait for another year, around half of your patient will achieve remission. And the last one is maintenance of endoscopic remission, means those who already were in endoscopic remission at 52 weeks, how many of them will continue to be in remission by the second year? And you can see the majority of those patients continue to be in remission in the second year. So we know like we have lots of patients, like more than 200,000 patients taking opasitinib, and this has been, we have 7 indications, so we have a lot of data about safety of opasitinib in both UC and CD. And with doses is different in gastroenterology versus dermatology and rheumatology. Rheuma, they only have the 15, in derma, 15 and 30. In the GI, we know we have a larger surface area, so we have an induction of 45 and maintenance of 15 and 30. So now moving to the SKyrizi, so just I will be not too detailed. So this is the risankizumab trial in CD. So there is also like 2 induction trial, the advance and motivate. The patient were taking 600 of risankizumab at 048, and then in maintenance trial they're taking the risankizumab 360 every 8 weeks, and those non-responders were allowed to take another extended induction, and you can see the completers at 52 weeks, and then there is an extensive trial. We'll talk about that later. So here the outcome is induction at week 12 and the maintenance at 52. And you can see also clinical response here versus risankizumab versus placebo. In the advanced trial, you can see there is a separation here, 41% at week 4 versus 25% placebo, and you can see there is clear differences in the clinical response. And co-primary endpoint, clinical response, endoscopic remission, this is clearly that risankizumab did better than placebo. And you can see the one that's a gray with the blue borders, this is the placebo. The other placebo is the patient who were in placebo were allowed to continue to be in placebo, but however, this is not counted for. So this is steroid-free remission, so steroid clinical and endoscopic outcome during maintenance, and those you can see the difference between risankizumab, 360 milligram versus a placebo, and you can see there is a difference in clinical remission and steroid-free remission in both in the induction and maintenance trial. In the maintenance, you can see the remission and response. Risankizumab did better than placebo. So this is a 3-year long-term safety. You can see this patient were followed up to 150 weeks of risankizumab, and you can see here the result. So this patient, which is OA, as observed, our patient who had failure or non-response, they're allowed to take a rescue dose of 120 milligram IV risankizumab, and and this is the AO, and the other patient who were taken out of the equation. So if you're taking a rescue risankizumab, then those will be excluded from the analysis as failure. So those will be in orange, and you can see the ones that maybe this affect more the one in orange. They did very quite good. Like this is at 52 weeks, and you can see more than 50% achieved endoscopic response. Endoscopic remission maybe less at 35%, and ulcer-free endoscopy 28%. This is at week 152.
Two
like
minutes.
3 years. I'll try, so just to summarize, the last thing is the sequence trial. So we know in IBD we have a problem with comparing drug to drug. We don't have a lot of RCT comparing medication. We have few RCTs. We're mainly relying on network meta-analysis. So this is one of the recent and latest sequence trial, which compared ustekinumab versus risankizumab. And you know the dosing is ustekinumab was taken IV by weight, and then every 8 weeks sub-Q versus risankizumab IV, the first induction doses, then every 8 weeks sub-Q. And you can see here the clinical remission was assessed at 24 weeks. Then the outcome was non-inferiority of risankizumab to ustekinumab. I did show non-inferiority at week 24. And in endoscopic remission, we can see risankizumab shows superiority over ustekinumab and reaching endoscopic remission. And also the secondary endpoint, if you go to CDI score, endoscopic response, steroid-free remission, and all outcomes at the secondary at week 48, risankizumab did better statistically than ustekinumab. So this was an open-label, randomized controlled multi-center trial. And this is also, like you can see here, the endoscopic remission versus mucosal healing and deep remission, which is endoscopy, clinical, and biochemical remission, deep remission. This all achieved by risankizumab versus ustekinumab. So to summarize here, and those patients were biologic failure. So we can see from this sequence trial, the risankizumab did better in achieving endoscopic remission at week 48, and there was non-inferior in clinical remission at week 24, and those compared to ustekinumab. I think that's like to summarize. I've tried to in 20 minutes summarize the data of upadacitinib and risankizumab and IBD and UC. Thank you.
Thank you. We will allow Dr. Ahmed only one question, short question, just because of the time.
Shihab, excellent talk. This is the future. Risankizumab, IL-23, and UPA, right? I think
I cannot say this is the future, but this is one of the good
one step
treatments.
Further, yes. Okay. So you might use it before ustekinumab, risankizumab in Crohn's.
Sorry, what's the question again?
In Crohn's, you are going to use it before ustekinumab, risankizumab.
You mean am I going to use risankizumab as a first-line therapy in Crohn's? Is that the question?
No, after anti-TNF, risankizumab will be the second choice in Crohn's before ustekinumab.
So risankizumab can be used not just after anti-TNF, you can use it as a first-line therapy or also as second-line therapy. We have seen the data in biologic failure. Your question, if you compare it to ustekinumab with the sequence trial, we can see risankizumab is a better medication than ustekinumab. Then I would say I use it, and maybe I would prefer it over ustekinumab, but I would use it also like a first-line therapy and a second-line therapy. This also depends on other factors, patient preference, other like disease excess and manifestations, fistulizing disease. So I cannot say for all patients, but yes, it will be a first choice medication and also can be a second choice medication.
I think we're going to end the session for now, and there will be a break, my guessing, for 10 minutes.
Okay.
Thank you.
Thank you.